The content of this podcast is based on medical fact and evidence-based practice from credible, authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics.
Hello, everyone, and welcome back to the FlightBridgeED MDCAST. My name is Mike Lauria. I'm an emergency EMS and critical care physician with a special interest in critical care transport and still flying actively as a flight and retrieval physician. We are back with our OB critical care series, and I'm very excited to have our returning guest, Dr. Alex Pfeiffer. She's an MFM fellow at the University of Texas in San Antonio and also shares a very keen interest in transporting these patients and has been working with myself and Liz Garcher. We are currently collaborating on a number of other projects, and I think that this is going to be a really cool thing moving forward to focus on transport of these patients. So welcome back, Alex. Pleasure to have you back.
Hey, Mike. Super happy to be back.
Today, we have another very, very interesting topic, and today's topic is Placenta Accreta Spectrum Disorder. So without further ado, let's get into it. So Alex, just start out by talking a little bit about what is the placenta accreta spectrum. And there's placenta accreta, increta, percreta, around the creta. How do you keep it all, organize it in your mind and remember it?
Yeah. So placenta accreta is one of those spectrums. The more contemporary way of thinking of placenta accreta is more as a spectrum nowadays. Historically and traditionally, we know placenta accreta as an morbidly adherent placenta, is the long and short of it. There are traditionally 3 stages to placenta accreta spectrum. Traditionally, those were known as accreta, which is when the placenta adheres to the myometrium or the muscle belly of the uterus. Increta, when that placenta starts to now invade the muscle belly of the uterus. And then percreta, which is when the placenta invades the entirety of the myometrium, crosses into the outer aspect of the uterus, and then sometimes into the extrauterine organs like the colon or the bladder. So the way I traditionally try to organize it in my head is, what is the extent of disease that I'm dealing with? Is it extrauterine? Is it just to the outside of the uterus? Or are we dealing with just intrauterine disease where that placenta is highly abnormal? Placenta accreta spectrum includes all grades of abnormal placentation, and like I'd mentioned, it's now referred to as an umbrella term of placenta accreta spectrum disorder. And this has been endorsed by both FIGO, RCOG, which is the Royal College of Obstetrics and Gynecologists in England, ACOG, and SMFM.
Okay. So it sounds like everybody's on the same page, and that just makes more sense. Sometimes I feel like we just like draw these lines in terms of it's this, it's that, or it's this, and it's really not necessarily the most accurate representation of the pathophysiology.
Exactly. It's definitely a spectrum, and there are lots of times and lots of scenarios where you can have a different type of adherence. You can have a focal adherence. You can have another focal, deeper penetrative disease, all within the placenta, all within the same placenta, I should say. So
even within the same placenta, it can be heterogeneous. It can be different areas of depth of penetration and invasion. Wow. Fascinating pathophysiology here. So how does this actually happen?
Yeah, good question. And it's something that is a hot topic in the world of maternal-fetal medicine. We still don't really know. The biggest theory that has been adopted by almost all experts in the field is the idea that it is an invasive disease. But sometimes the way we think about it now, and the way that the theories has evolved, is that we think of PAS as a disease of uterine dehiscence, which is when that uterine wall actually opens up. And that's usually caused by previous uterine scarring from instrumentation, like a dilation and curettage, or cesarean section, where we actually open up the uterus. And so over time, as you can imagine, just like our skin scars, the integrity of the uterine wall wall itself is compromised. And so what happens is there's an abnormal attachment and a superhighway of vascularity, so to speak, that occurs when delivery happens and the placenta fails to separate normally like it normally does. Uterine muscle dehiscence likely accounts for the degree of invasiveness. And it's likely a precursor. Cesarean scar pregnancies can also be a precursor to PAS. But the long and short of it is an abnormal trophoblastic invasion through the endometrium and into the myometrium, likely caused by a previous uterine dehiscence or a previous scar.
And now this, in terms of, well, actually, before I ask you this, let's take one step back and let's just review for everybody, because I think this is important globally for all our listeners, whether you're a doctor, nurse, or paramedic. Just briefly go over normal placental implantation as compared to what you just discussed.
Yeah, so normal implantation occurs when you have, and this goes way back to med school for us, but normal placentation is when the blastocyst, or that original embryo or embryonic unit, hatches, and implantation occurs within the lining of the uterus, which is the lining right before the muscle portion of the uterus. And once it attaches to what we call that decidua or endometrium, that allows for natural normal invasion into the maternal uterine cells. The embryo does a bunch of other different things from a pathophys standpoint that allows for adequate implantation into the uterus as the gestation moves along.
Gotcha. Okay. That was an awesome review. Even I need reviews like that from time to time. So even the most fundamental medical school concepts.
Yeah.
So that was awesome. Now, getting back to kind of where we were at, and you discussed the pathophysiology of how this happens. One thing I really wanted to hammer home for our listeners and really foot stomp this is, so the placenta has abnormal adherence and invasion into the uterus. Like, what's the big deal, right? Like, why is it so morbid?
It's morbid because it causes a lot of hemorrhage and a lot of blood loss, right? The number one reason for morbidity and mortality with this spectrum or with this disorder is bleeding. Because as you can imagine, as you attempt delivery and delivery of the placenta, that those shearing forces of the attempted placental removal causes opening of those abnormal vessels that have now matured over 9-10 months of the pregnancy. And that opening of those vessels is essentially a nidus for a hemorrhage fountain, so to speak, where now the uterus is unable to become more tonic or become more firm and clamp down and becomes more small as we go into the later parts of delivery. And so that opening or those abnormal opening of those vessels basically stay open until the uterus itself is removed. And in 1 minute of blood flow with the placenta still in place, or with that damage to the endometrium or the myometrium, I should say, of the uterus, over 500 cc's of blood runs. So in 1 minute, you can accrue a 500 cc blood loss. And as you can imagine, over time, as those minutes pile on, your blood loss increases, furthering your risk for DIC and then ultimately mortality. Yeah.
Wow. That is something that just I wanted to hammer home to all of our transport crews out there. This point that Alex just drove home with the abnormal implantation. Right. You cannot get the normal constriction of those uterine vessels. And we're always remembering that uterus, that gravid uterus, especially, in the third trimester, is getting 10 to 30 times the amount of blood flow it normally does. And this I learned from Alex just a little while ago, 500 cc's a minute. That's a tremendous amount of the cardiac output. So you can understand why this can get really bad, really, really quick. Awesome. So that was a great review of the pathophysiology, but let's talk about how common this is. And this I really wanted to touch on and talk about because I learned some very interesting things here too. I knew it was becoming more common, but in some of the literature going back to the 1980s, it was reported about, less than 1 in 1,000 pregnancies. Now it's closer to 3.6 or sometimes higher. If you do the math there, that's about 1 in 272. There's a lot of pregnant ladies in our region of the country. And therefore, like if you look at that, 1 out of 272, Alex was saying in their very busy center, you're looking at least a couple of months. This is a very real thing, especially as we see centers around various rural regions closing down. I think we will see more of these patients presenting to emergency departments and smaller hospitals not capable of dealing with this. And we'll talk about a little bit later why it's so important that these patients make it to a level 3 or level 4 center with advanced care and maternal-fetal medicine specialists. That rise is not insignificant, I think, and is becoming more and more common, especially when you think out of that group, the mortality has been reported as high as 7%, which sounds relatively small, but with a frequency of 1 in 272, that is absolutely not insignificant or small numbers overall. So let's move forward and let's talk about, so we have a patient, you have a patient, Alex, that you're getting called from an outside ED about, and what are some of the risk factors? What are some of the things that really get the hairs in the back of your neck standing up and concerned that this patient may have, maybe has something along the Placenta Accreta spectrum?
So the most common defined risk factor is previous cesarean section. Now, when you add a history of a previous cesarean section, no matter the number, on top of the presence of placenta previa, which for our listeners out there, placenta previa is when the placenta covers the cervix. The cervix is that small portion of the lower uterine segment that is made of collagenous material or collagen that dilates as women labor, and that opening or that dilation allows for the fetus to pass through. And so when the placenta overlies that cervix, we call that a placenta previa, and it's a contraindication to vaginal delivery. But we know that far and away, the biggest combination for risk for placenta accreta spectrum is history of cesarean section and placenta previa. There is a physician by the name of Dr. Robert Silver in the world of maternal-fetal medicine, who's actually one of my mentors at the University of Utah. He actually wrote a landmark paper that we follow, and he mentions in his study that the risk of placenta accreta spectrum disorder at the time of the first C-section in the presence of placenta previa is already at 3%. When you add more cesarean sections, or more, the number of cesarean sections increase, that risk profile increases. So the risk at the time of second cesarean section in the setting of the presence of placenta previa is about 11%. The next one would be 40%, and so forth, to even upwards of greater than 61%. So again, if you are receiving a call and a patient has a history of a previous cesarean section in the setting of a placenta previa, those should definitely cause your spidey senses to turn on. Other risk factors, advanced maternal age, so that's for our moms who are greater than the age of 35, previous uterine surgeries, multiparity, history of even dilation and curettage or a myomectomy on the uterus, and then Asherman syndrome have all been identified as risk factors before as well.
Nice. Okay. So now we understand some of the risk factors. I think it's worthwhile briefly going over for the audience, like how you guys actually diagnose it. I don't think we need to get into like the deep statistics or the sensitivity and specificity of some of the tests, but what might you see if you pick up someone in the paperwork from the outside hospital that has identified this?
Yeah. So some of the things, and again, not trying to get into the nitty gritty, but some of the things that we look for are, is there a lot of Doppler flow? Is there a lot of that hypervascularity, and especially in that lower uterine segment at the site of a previous cesarean section along the uterus and along the bladder? Is there a hypervascularity? Is there a loss of the myometrium so that we can actually measure how thick the muscle belly of the uterus is? And if we see that's less than 1 millimeter or totally absent, that's also very, very ominous. Other things that we look for are what we call like a placental bulge. bulge, and that's when the placenta is literally causing the uterus to kind of bulge into the bladder, and we can see that on especially transvaginal ultrasound quite well, and that it's starting to become increasingly a very accurate and highly predictive marker that we use to help diagnose placenta accreta. And then lastly, what we look for as well is not only that hypervascularity and the abnormality in the muscle belly, but we also look for what we call placenta lakes. And basically, we look for like a moth-eaten appearance of the placenta at the lower uterine segment. And if that looks abnormal and has abnormal Doppler flow, that's highly, highly ominous of placenta accreta spectrum disorder.
So if you see an ultrasound report that describes some of those things, and I'm assuming those lakes are basically like hypoechoic, dark, or anechoic spots that are essentially fluid or blood.
Right, absolutely.
Concerned.
And that's the most highly predictive marker that we look for right now, at least in all the contemporary studies.
And then I think it's important to recognize that even if you have a normal or you have none of these findings, it doesn't completely rule it out, correct?
You know, we talked about way back when the pathophys with regards to previous uterine instrumentation and scarring to the uterus, but there are very rare circumstances and scenarios where somebody can have a placenta accreta in the absence of all these risk factors. So, you know, it's definitely not, ultrasound diagnosis is not 100%, but it does reach sensitivities of greater than 90%.
Cool. Okay. So now I think it's worthwhile getting into how these patients are going to present and how we're going to take care of them and what we can do as critical care transport crews. So I think we were talking about it before, and at least from what I can glean from the literature, probably essentially 3 scenarios that we may find in the transport world. And let's start out with that first one. So a patient presents and you know that they actually have placenta accreta.
You know, if a patient walks into your institution and has that known diagnosis and they're coming in with a chief complaint of vaginal bleeding or vaginal spotting of any kind, of any amount, that should again send those alarm bells in your head, and you should probably start considering transfer of this patient to an accreta center of excellence or a tertiary hospital that has a capability to take care of this patient in the event that there is a decompensation for whatever reason. If you are already a tertiary center, then notifying all of your multidisciplinary team that the patient is in-house, regardless of what their chief complaint is, regardless of the acuity level, just having that knowledge base and that warning is very, very important.
Let's also kind of foot stomp this for everybody, because again, this was something that it took me a while to figure out. It's like, okay, so they've got a little bit of bleeding. Like, why do they really need to go to a multidisciplinary center? If they're just spotting, it's just some bleeding. Why do they need to be flown 30 minutes, an hour, to a level 3 or level 4 center?
Yeah, super important. So what we know is that the more episodes of vaginal bleeding that a patient with PASD has, the higher the chance of emergent delivery. And so we actually did a study at our institution where we looked at a cohort of about 145 patients, and we saw that one of the prediction values for both cesarean hysterectomy and ICU admission is the number of episodes of bleeding. And we saw that for patients who had greater than 2 episodes of bleeding at any point during their gestation, they had a much higher risk of both ICU admission and morbidity because of their disease. And so really the rule of thumb for these patients is for any sort of vaginal bleeding, admitting them to the hospital for an extended amount of observation is very key and very prudent to help avoid those emergent scenarios.
Gotcha. And I know that this is again, and one of the reasons we transport these patients to these centers is sometimes these decisions are very nuanced. They need very close monitoring. But ultimately, in general, once this has been identified and they're transferred, and our crews drop them off, what is sort of the terminal pathway for them most commonly, would you say? How do you manage them?
So typically once they're transferred or transported to a tertiary center and they've had one episode of vaginal bleeding and they're in that early preterm gestation, anywhere between 24 to 34 weeks or so, typically we're not really letting that patient go home. Usually it ends up with basically like a terminal sentence in the form of you're staying in the hospital likely until you deliver, just because, again, that morbidity is so extremely high after one episode of bleeding. So once they're admitted to our institution, like I had mentioned previously, we have the whole multidisciplinary team alerted that the patient is in-house. This includes NICU, this includes anesthesia, our vascular surgery, trauma surgery team, our critical care physicians, our interventional radiologists, obviously OB and MFM, and that whole entire team on top of our nursing leaders and nursing leadership is involved in the care of this patient.
Yeah. And I think that's important to recognize. And when crews are like, oh, well, there's just like a little bit of bleeding, why are they going? Well, it's because it requires this whole team. And if these patients go south, it can require a lot of people to already understand and have a plan in place and be able to activate things like get someone into an OR right away, get a massive transfusion ordered and immediately available. Things that if things start to go downhill at an outside facility, it can be really, really bad, and they just will not have the resources and availability of things to manage it, because the kinetics of this whole thing just evolves so quickly when patients start to bleed under these circumstances. So hopefully that clarifies for everybody the importance under those circumstances. But now let's transition out, because let's talk about, so you actually a patient has gone for they've already initiated a cesarean section, or and now it's unknown and they discover it at the time of cesarean section. What would be the trajectory and transport plan under those circumstances?
Yeah, this is the crux of it all, right? And this is where morbidity and mortality happens. And so, before I kind of get into what that pathway looks like, the Society of Maternal-Fetal Medicine came out with a checklist or a special statement with regards to Placenta Accreta Spectrum Disorder patients. This was actually published this year in January. And basically they came out with a beautiful checklist that I highly recommend any single provider or staff member who will ever come across these types of patients to look over. And this is hopefully something that we can put in our show notes. But the biggest critical questions that you want to ask both yourself and your team are two. One being, does this hospital have the resources to manage Placenta Accreta Spectrum? And number two, can transport to a PAS referral center be safely arranged? And so as long as you've mulled over those couple questions, then we can start attacking kind of what our trajectory is going to be like, or what our plan is going to be like. And so in the event of an unexpected or an undiagnosed Placenta Accreta Spectrum patient, if you are proceeding with delivery, you want to make sure that you mobilize all your resources and your team. These resources include large bore peripheral IVs, arterial access, preparing for a massive transfusion protocol, notifying all of your subspecialties like we had previously alluded to, including blood bank, and determine the optimal OR to perform. Typically, these cases aren't the best cases to perform on an L&D. They may be more appropriate for a main OR or a hybrid OR that has vascular capabilities. And then you want to make sure that all of your procedural consents are updated, including a cesarean surgical consent, a hysterectomy surgical consent, and so forth. And then one thing that we also don't typically talk about is identifying that good or appropriate healthcare proxy. And so having that difficult conversation with the patient prior to any decompensation is very important. Now, let's say you've already delivered and you notice that the placenta is just not separating like normal and you're starting to encounter a lot of bleeding, or even in the absence of overt bleeding, you see that on the outside or on that gross inspection of the uterus that things are looking highly abnormal. And the patient has a history of couple C-sections, and you know she has a placenta previa, and the outside of the uterus looks very bulgy, it looks very angry and blue, maybe there's a uterine window. If the patient is stable, I highly recommend, and this is again endorsed by both ACOG and SMFM, that you temporize the patient and get them ready for transport. It's very, very important that we pause, assess, and determine what we want to do with this patient if she's stable. Now, if she's unstable and is hemorrhaging, unfortunately, the ultimate goal here is to proceed with a hysterectomy.
I think a couple things I wanted to touch on there. Alex brought some fantastic points, and we will definitely put the checklist in the show notes. A couple of things that I think are often not considered. This is definitely a case. Normally, I mean, bringing family members and whatnot it's always important, and we always try. Having a surrogate decision maker travel with this patient, especially if they're too sick or intubated or don't have the capacity to make decisions for themselves, is so important, because these are going to be big, important, potentially life-changing decisions. So having the partner, having a surrogate with them in transport is super important. And Alex mentioned this is there in terms of temporizing things. That temporizing could entail actually stopping, packing the abdomen, and transporting a patient with an open abdomen, which is something we'll have another whole separate podcast on at some point. So you could see a number of different scenarios here. I think probably the most important scenario that we could potentially intervene on is the patient who's actively hemorrhaging. And that I think, up till now we've talked about a lot of things, but aside from the physical transport modality, the aircraft or the ambulance, this is, I think, where like the ICU, the critical care side of things can really, I would say, we don't make the terminal difference. We're not the ones who are doing the ultimate procedure, but helping out with critical care support stuff. So if they're intubated, obviously managing analgesia, sedation, and the ventilator. But there's really, I kind of throw it into like 5 things that I think critical care and transport specifically can offer. One is the very close monitoring. Like we said, these patients can decompensate incredibly quickly. Alex brought up the 500 cc's a minute into that uterus, and with a vessel that can't clamp down, that could be a substantial amount of blood loss. So I think if you are capable as a physician, or what's in your protocols or guidelines, these are patients who I wouldn't necessarily wait around or wait or withhold transport to do this. But if you can, en route, getting an arterial line in place, or if you're on your way to pick them up, the anesthesiologist or whoever's there, if they haven't, I would have them put an arterial line, if at all possible. The other thing is, under certain circumstances, there are case reports of having intra-abdominal bleeding, or bleeding that is not readily identifiable, that's actually coming from the uterus itself. There are times I think that ultrasound might be helpful. Again, I wouldn't withhold transport. I would assume they're bleeding. I would resuscitate them as such. But in the presence of uncertainty, it's certainly not unreasonable to use ultrasound as you would for other critical care pathologies. Access and volume resuscitation. This is huge. This is like our bread and butter, right? Definitely bigger is better on these patients. 2 14 to 16 gauges. Everybody always says 2 big, large bore IVs. Again, if you have the capability, or if you have an anesthesiologist that can while you're traveling out there, I'd get a cordis in these patients, especially if you're going to need to put a lot of blood into them really, really quickly. If you're a flight crew that can't do that, they do have rapid infusion catheters. So let's just say this was not anticipated. You have like a small 20 gauge. You can easily upsize that into a 7 French or 7.5 French peripheral line. That is something that nurses and paramedics can do, and bring all the blood. Bring all the blood, bring all the blood, bring all the blood. If you normally carry a small blood cooler with 2 of reds or 2 of plasma, this may be a case where you talk to your blood bank ahead of time and bring additional products, at least the equivalent of a couple of coolers, or ideally, I would say 3 and a pack of platelets at least. If you have access to things like cryoprecipitate and some of the other products, would not be unreasonable as well, because you may need them, and you may need them very quickly. And often smaller hospitals will have to thaw plasma. They won't necessarily have all of the supplies that you need there, while you might. Anything to add before I move on, Alex, on the access and volume resuscitation side of things?
No, I think you touched everything. I think just having that balanced resuscitation is obviously what our goal should be. The only other thing that I would mention as well is just with regards to maternal stability and resuscitation is, let's say the abdomen is nice and tightly packed. We also have to be mindful of what's happening underneath the drapes, right? So making sure that we're keeping track of what's happening down below in terms of vaginal bleeding is very, very important. I can't tell you how many cases we've had of, we have all this bleeding going on up top intra-abdominally, but we fail to realize that maybe there's a liter of blood spilling on the floor. And so it's very important that if that patient does have vaginal packing in place, that our nursing staff is mindful of what the output is like from down below, right? Especially in a patient who was previously laboring, maybe her cervix is a little bit dilated, and that allows for some of that blood to escape down below. And so it's mindful to let our critical care providers and our anesthesiologists know what that output looks like from down below, not just from up top. And just to help with scope as well, about one fully saturated pad is worth about 80 cc's or so. So just to kind of help with quantifying what kind of blood loss we can accrue, down below.
Oh, that's super helpful to kind of keep that general number in mind. Let me ask you this, Alex, from a surgical standpoint, when patients need to be temporized, so packed, left open, and transported with an open abdomen under these circumstances. So, often some of our patients that undergo damage control laparotomy, or they have intra-abdominal sepsis and get washed out and they're left open, they'll have an Abthera, or they'll have some device in place, or at least some drains in the abdomen. When you guys pack with sterile towels and put a temporizing barrier over that in the iota band or whatever, do you also have drains in the abdomen?
We typically don't put drains in the abdomen. That's more so done in the trauma literature. There's really not much data out there, at least with regards to this subset of patients and placenta accreta spectrum. But as long as that abdomen is nicely packed and ready for transfer, that's the biggest temporizing measure that you can do.
The other thing we run into, and I did not realize how common this was in this population, but up to about 30% of these patients can develop evidence of coagulopathy to some degree. Remember when we talked about in the DIC lecture, the uterus and the placenta in particular, the placenta is a tremendous source of tissue factor. And that interaction can release tissue factor and actually cause various degrees of coagulopathy and or up to DICA, like the extreme end of that spectrum. So I think one of the things for crews to keep in mind is to, like Alex said, if in doubt, balanced resuscitation. So 1:1:1. That is, although there is not super strong evidence for it, I think it's safe, I think it's reasonable, and it's definitely recommended by the various societies. If you do have an institution that has actually sent a coagulation panel, an emergency hemorrhage panel, I think it's reasonable for crews to understand, like, what's a normal fibrinogen and what should you be doing if the fibrinogen is low, giving them cryo, what is acceptable for platelets and what's acceptable for some of those other factors, as well as beginning to learn to interpret some of these viscoelastic tests that give you really good idea of exactly what a patient's coagulation, how their coagulation function actually is in the body, as opposed to some of these biomarkers. If in doubt, default to a balanced resuscitation, and this may have to be going in through one of those big IVs very, very, very quickly. So managing their coagulopathy. I think the last piece of it is, and this I would say is not super, super common, but when you think about the degree of hemorrhage and the speed, the rapidity, and the volume of resuscitation, it would not be uncommon for some of these patients to get at least 7 to 10. I've seen or heard of as many as 20 or more units of product in a really, really bad, bleed. They are at risk for complications of transfusion, specifically taco and trolley. And so this is another place where a crew should be very mindful of when this is going on. If a patient's not already intubated, that beginning to show signs within 6 hours of starting a pretty substantial, robust transfusion should be concerning for transfusion-related lung issues, specifically taco and trolley. Anything on the coagulopathy or the transfusion issues, Alex, stuff that you've seen?
Yeah, the only other thing I would add is just from a maternal physiologic standpoint with regards to taco and trolley. After delivery of the neonate, we see an auto transfusion of an additional 500 cc's or so of fluid back to mom. And so just being mindful of our ins and outs is critically important with regards to resuscitation. With regards to coagulopathy, typically levels of fibrinogen greater than 300 or so is kind of the limit that we look for, or what we use as our threshold for impending DIC in obstetric patients.
Gotcha. Good numbers to keep in mind. And the last part is transport and logistics coordination. Now, I'd like to throw something out here, which I think this is purely my opinion. This has not been really discussed in the literature at all, but we talked about some facilities not having the specialized capability to deal with these patients. There are cases where actually flight crews, transport programs have delivered an MFM or OBGYN to an outside hospital to help manage very complex disease, not necessarily Placenta Accreta Spectrum Disorders, but various other problems that require surgical specialty, and the patients may otherwise not be stable enough to be transported to a receiving facility. So this, I think it's worth at least keeping this in mind as an option of using transport and using critical care transport to bring specialty care out to smaller facilities and institutions as an intervention in and of itself, including bringing extra blood, additional products like cryo, whatever else you can think of, having that stuff brought with you and actually doing the resuscitation at the outside hospital. We also talked about making sure we're bringing a surrogate decision maker with them if they are not capable of making their decisions. Anything else in the transport logistics that your crews have found, Alex, or that you recommend if someone was transporting one of these patients?
You know, I think just with regards to transport and communication with the tertiary center or between centers, I think it's critically important that we identify what's going on, right? So knowing, again, kind of going back to what the risk factors are for PAS and describing that to the accepting facility, to those providers. So saying that this was an OB patient who underwent a C-section. She had history of, let's say, C-section times 3 with a previa, and underwent a significant amount of bleeding. Those, just verbalizing that to the accepting facility providers is extraordinarily important, because that can help, again, mobilize all of the extra resources and teams that we need in an expeditious manner, rather than it having been a surprise. Because as you can imagine, there are a multitude of other reasons for hemorrhage in obstetrics, but knowing that this type of hemorrhage is associated with placenta accreta spectrum is an entirely different type of management plan. And Mike, you and I had talked about, the use of uterotonics in these types of scenarios, and unfortunately, they don't seem to work quite well. You might get a little bit of tonicity back, or that uterine tone. However, as long as that placenta stays in place, your tone is going to be atonic, and you're going to continue to have bleeding until you perform ultimately a hysterectomy. There is a role for TXA in the literature. There is definitely a role from both a trauma standpoint and from an OB standpoint for infusing TXA, so I would definitely recommend that, whether that's during transport or at the time of delivery. And Pitocin does, again, uterotonics will help minimally, but ultimately the definitive measure here is a hysterectomy. Otherwise, going back to the original question with logistical coordination. So again, that communication is key. Packing the abdomen, balanced resuscitation, and then clear communication with the healthcare proxy, and then determining what's going to happen to the neonate, right? And so you had mentioned maybe we have to bring an MFM over, or a gynecologic surgeon over to these facilities, or a trauma surgeon to these facilities to help. But then also, is there a role for the NICU team to come as well? Typically, unfortunately, these cases tend to happen emergently in the preterm gestation, again, kind of between that 30 to 34 week mark. And so, as you can imagine, the neonate will definitely need some either respiratory support, or any other type of support to help once it's born, especially obviously again, if the patient is under general anesthesia for whatever reason already. And then lastly, if you have already performed a C-section and you notice that this is ominous for a placenta accreta spectrum disorder, and you've packed, discussing with the anesthesiologist what the next intervention should be, i.e. general endotracheal anesthesia. And typically, like we all know, cesarean sections are performed under neuroaxial anesthesia. And so at that point, if you're preparing for transfer, asking for support or for the opinion of an anesthesiologist with regards to intubation is important. But otherwise, I think, Mike, you've hit pretty much everything with regards to transport and logistic coordination.
Yeah, that was, in particular, the two, I think, most important points, which I forgot to mention there, were the NICU team, having them available. This may be a dual transport, so it may require 2 aircraft, or it may require 2 ambulances, or some combination thereof, so that you have the NICU, the neonatal critical care capability there as well. And I'm really glad you brought up the airway management thing. That, again, would be a joint decision between the sending facility, the receiving facility, and the transport crew as what might be safest, especially if they're already bleeding. The safest and most appropriate thing may be to actually work with the anesthesia team at the sending facility to intubate the patient and provide our typical management via ventilator with appropriate analgesia and sedation. In case things go downhill, trying to actively resuscitate and manage an airway in the setting of a acutely deteriorating patient in midair may be very, very challenging. And as we mentioned, things can go downhill pretty quickly. So this was an awesome review of placenta accreta spectrum disorder. We started talking about what it is, what causes it, and in particular, I think we foot stomped a couple things, namely that things can go downhill very quickly from a hemorrhage perspective, and Alex talked about why, as well as, and Alex really hammered on this too, is identifying the risk factors up front, trying to identify these patients as soon as possible and preventing active bleeding. We talked about both diagnostics and and went through several examples of both the patient with a known placenta accreta and patients who we did not know about until the time of delivery and how we're going to manage them. And finally, we went over essentially, I think, the 5 most important things that we can do for a patient who is already hemorrhaging and critically ill as far as the transport crew goes. Making sure we have very good monitoring, invasive monitoring if needed, access and blood resuscitation, treatment of coagulopathy, managing any transfusion-related issues, and the transport logistics that we talked about. Any other pearls that you'd like to leave the audience with, Alex?
Yeah, I think just one more thing that I'm not sure if we clearly mentioned is, if you are at a lower level hospital system and for whatever reason you have to proceed with a C-section, knowing that a patient likely has placenta accreta spectrum disorder, once you've identified that disease intraoperatively and you've already delivered the neonate, it's very important that you quickly close up your hysterotomy. And you can do that with a whip stitch, one single layer. to again close that uterine muscle and try to constrict all those vessels that potentially could get sheared. And then most important thing, not delivering the placenta. As you can imagine, if you try to pull on that placenta, like we previously mentioned, that shearing can cause an extraordinary amount of bleeding. And so again, once you've made your hysterotomy, close and deliver the neonate, closing the hysterotomy very, very quickly, and try to pack, temporize, and transfer over is key.
I think that's a super important point, right? If we get out to break, don't mess with the placenta.
Don't touch
the placenta. Don't poke the bear. Don't mess with the placenta.
Do not touch it. That is the biggest thing that we tell, especially our learners here when we perform these cases, and even in the most controlled manner, do not touch the bear. Don't touch it.
Don't poke the bear. Don't poke the bear. Awesome. Well, this has been a fantastic episode. I learned a lot. I think this is great for our listeners and a fantastic addition to our OB Critical Care series. Alex, thank you so much for joining us. And ladies and gentlemen out there, please take care, fly safe, and we'll see you on the next episode.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.